This is the overview of chronic lymphocytic leukemia, commonly abbreviated as CLL. It utilizes multiple illustrated sections within a temple-like structure to simplify complex medical data. The journey begins with the clinical features and genetic foundations, where a segment labeled Clinical Symptoms and Genetics characterizes the typical patient as male and over 60 years old, suffering from symptoms such as fatigue, generalized abdominal discomfort due to and swollen liver and spleen. This initial analysis is linked to a genetics tree, which branches into key prognostic indicators, distinguishing the more common B-cell CLL with specific chromosomal deletions from the rarer T-cell variations and their associated genetic risks. Specifically, B-cell CLL with a 13q deletion indicates a better prognosis, whereas trisomy 21, or the Philadelphia chromosome translocation T, in T-cell CLL suggests a much poorer clinical outlook. Further refining these genetic risk categories, the diagram transitions to molecular genetics and prognosis to map specific genetic mutations and markers against outcomes. It showcases how variables like the IGVH variable region gene, when mutated in 70% of cases, are associated with a better prognosis. In contrast, other markers including the zeta chain associated protein 70, increased CD38 expression, and specific tyrosine kinase activity signal DNA synthesis and tumor cell proliferation, leading to a more advanced disease stage. The role of microRNA is also detailed as a mechanism that destroys specific messenger RNAs to increase the expression of BCL2, which promotes angiogenesis and dissemination by providing oxygen and nutrients to the growing tumor cells. Proceeding from these underlying genetics to practical diagnosis, the guide illustrates lab findings where microscopic views detail hallmark features like smudge cells, which are fragile blasts that rupture during slide preparation. Mature lymphocytes in CLL often display a soccer ball appearance due to their clumped chromatin. Diagnostic cell surface markers are also highlighted, such as the characteristic CD5, which is interesting because it is normally a T cell marker but appears on these malignant B cells alongside CD21, CD22, and CD24. Visual descriptions are included for associated complications like autoimmune hemolytic anemia, characterized by spherocytes and reticulocytosis, as well as hypogammaglobulinemia, which is a deficiency in protective antibodies. Following a diagnosis, the staging of the disease is crucial for management, which the infographic summarizes through a direct comparison of the Rye and Binet systems. The Rye staging progresses from stage 0 involving only lymphocytosis to stage 4 involving thrombocytopenia, while the Binet system categorizes patients based on white blood cell counts and the percentage of prolymphocytes, ultimately guiding treatment. The chart outlines current therapeutic strategies focusing on the use of monoclonal antibodies such as rituximab and alemtuzumab to activate complement activity and cellular cytotoxicity against CLL cells. The standard combination chemotherapy known as FCR, consisting of fludarabine, cyclophosphamide, and rituximab, is highlighted as the gold standard. The final panel distinguishes CLL from key variations including hairy cell leukemia, which is positive for the tartrate-resistant acid phosphatase stain, and Hodgkin's lymphoma, which is famously marked by its signature Reed-Sternberg cells with an owl's eye nucleus appearance.